Hi, this is Piyush Bhargava and you're watching the Brain Perfusion Imaging teaching file. Let's review the clinical imaging protocol. There are several indications for evaluating patients with brain perfusion imaging and brain SPECT. These include evaluation of patients who have complex partial epilepsy to identify the site of seizure focus so that it can be surgically resected. Patients who are being evaluated for brain death, and patients who are being evaluated for dementia. For dementia evaluation, a better study is FDG PET looking at brain metabolism. Typically, the perfusion and metabolism are well matched in brain tissue, and so the normal distribution of FDG on a PET versus technetium 99M HMPAO or ECD on a brain SPECT is not significantly different. For brain perfusion imaging, the radiopharmaceutical is 20 millicuries of technetium 99M HMPAO or ECD. The tracer is injected IV. For brain death studies, we acquire dynamic flow images immediately after tracer injection. For brain SPECT, we wait for 30 minutes and then acquire a SPECT of the brain. The mechanism of uptake is blood flow. Physiologic distribution is seen in the brain with most intense uptake in the gray matter, followed by white matter and absent activity in the ventricles. The critical organ is the gallbladder. Case number 1 shows multiple transaxial, coronal, and sagittal images from a normal brain SPECT. Normally, most intense activity is seen in the occipital cortex, followed by the subcortical nuclei, the basal ganglia, and then followed by the cortex. The cortical activity is typically normally it is symmetric. So that's the appearance of a normal brain SPECT. Case number 2 shows an abnormal brain SPECT where on the transaxial images, as we go from superior to inferior, we find that there is a large perfusion defect in the left MCA territory from a prior left MCA infarct. So that's how an infarct would look like on a brain SPECT. The next set of transaxial images are from an FDG PET-CT study of the brain. The finding here is in the right temporal lobe, seen here. There is a photopenic defect from a prior surgical resection cavity. A primary brain tumor was removed from this region, and now we are trying to evaluate if there is any evidence of recurrent disease. Sometimes in this situation, MRI of the brain with and without contrast is limited, and we use FDG PET to see if there is any hypermetabolism in recurrent or residual brain tumor. So the resection cavity is expected to be photopenic. The margins of the resection cavity are also expected to be photopenic, which they are not. There is linear increased uptake around the margin of the resection cavity, which is consistent with tumor recurrence. Case number 4. These transaxial images are from an FDG PET-CT scan of the brain in a patient being evaluated for dementia, and they show findings characteristic of Alzheimer's disease. As we go from superior to inferior on these transaxial images, we find that there is bilateral parietal hypometabolism, right more than left, seen here, and more inferiorly there is bilateral temporal hypometabolism, right worse than left, seen here. This pattern of bilateral parieto-temporal hypometabolism, initially which may be asymmetric, but later becomes symmetric, and in later stages also tends to involve the frontal lobes, is characteristic of Alzheimer's disease. The rest of the areas which show preserved or normal uptake include the sensory motor cortex, seen here on the right and on the left, the subcortical nuclei, seen here on the right and on the left, and preserved activity in the visual and the occipital cortex, seen here. So, parieto-temporal hypometabolism consistent with Alzheimer's disease. Transaxial FDG PET-CT images in a patient being evaluated for dementia. The finding is bilateral frontal hypometabolism consistent with frontal lobe dementia or Pick's disease. FDG PET images of the brain from a patient being evaluated for tumor recurrence. The left side of the brain near the vertex is where the primary tumor was removed. The resection cavity is photopenic, but the margins of the resection cavity show hypermetabolism consistent with tumor recurrence. Case number 7, these are transaxial and coronal images from an interictal FDG PET study of the brain. Interictal studies are performed on seizure patients when they're on seizure medication. We inject them with FDG and acquire a PET acquisition of the brain. During the interictal phase, when they're not having the seizure focus is hypometabolic compared to the contralateral side. So here the finding is seen in the right temporal lobe, which is hypometabolic compared to the left temporal lobe. So this would be the likely source of the seizure focus. This finding is correlated with an ictal SPECT study. And ictal SPECT is performed when they are taken off the seizure medication, admitted to the hospital under EEG and video monitoring, and right at the onset of seizure we inject the tracer, preferably within 30 seconds, and then we wait and acquire a brain SPECT. During an ictal phase, when the patient is having a seizure, the seizure focus becomes more active compared to the contralateral side. So the interictal findings are compared with patient's history, EEG findings, and also, if possible, the ictal SPECT study. So here we have right temporal hypometabolism in an interictal phase consistent with presence of a seizure focus. Another patient with similar history, we are looking at transaxial and coronal images from FDG PET-CT study of the brain showing left temporal hypometabolism consistent with presence of a seizure focus. We rarely do the studies, brain perfusion studies, using acetazolamide or Diamox to evaluate cerebrovascular reserve. The physiology of these studies is similar to doing a cardiac stress test, where we inject a vasodilator and then we inject the tracer and we see if any flow heterogeneity has been induced by vasodilatation. So we have two studies on the same patient here on case number 9. Transaxial images on the top and transaxial images on the bottom. The images on the bottom have been acquired using Diamox, which was injected as a vasodilator before the SPECT, and it produced a perfusion defect in the left cortex compared to the right, and on the resting study without Diamox, the defect fills up. So there is compromised cerebrovascular reserve on the left compared to the right, which was exposed on the brain SPECT using Diamox. Another patient with a similar history, two studies performed with and without Diamox. They do have a history of prior infarct, and we see a fixed defect here on the left cortex consistent with the prior infarct. But the MCA territory anterior to the infarct shows a perfusion defect which is reversible. So this is again evidence of compromised cerebrovascular reserve seen with Diamox. Case number 11 shows multiple dynamic studies on the top and then static spot views on the bottom. This is a brain death study where the tracer is injected IV and dynamic flow images of the head and neck are acquired over a period of time, which we see on the top. As we go through these images, we find that the tracer goes inside the brain and it stays there. On the spot views that were acquired after the flow study, we see intense activity in the brain, and this study would be negative for brain death. Case number 12 shows imaging findings of a study positive for brain death, where the flow images do not show any activity going into the brain. This is the apex of the right lung, this is the apex of the left lung. There is faint activity in the internal carotid circulation seen on the right side, but there is no activity seen inside the brain. On the delayed spot views, we see photopenic defect in the brain, and there is scalp activity from external carotid circulation. These images have been captured by cranking up the intensity, and that is why we don't we don't get to appreciate the hot nose sign, which is an indicator of perfusion in the external carotid circulation and not in the internal carotid circulation, and is a supportive finding of brain death. So this patient is brain dead. Another infrequently performed brain SPECT. This is a patient who is HIV positive, and on the right we have transaxial images showing a ring enhancing lesion with significant mass effect on the left in the subcortical white matter. In an HIV positive patient, frequently the question is toxoplasmosis versus lymphoma, and the nuclear medicine study we do for this purpose is thallium 201 chloride brain SPECT. So thallium is injected IV and a brain SPECT is acquired. On the transaxial images of the thallium SPECT, we see focal increased uptake in the lesion on the left, which would be consistent with lymphoma. Toxoplasmosis does not take up thallium 201 chloride. So those are some of the patterns that you can expect to see on brain perfusion imaging, brain SPECT, and brain FDG PET. Thanks for watching.